Thank you very much for that introduction. Good morning, everybody. Dr. Masaki did a great presentation on dementia, focusing on Alzheimer's disease. Now that you're all experts on Alzheimer's disease, my role here is to talk about what treatments are available. And I'm going to try to go through my presentation a little quickly so that we'll have time left over for questions. Please do keep track of what questions you have for us at the end of the presentation. So when someone gets diagnosed with Alzheimer's disease, what treatment is offered by doctors? And these are the traditional medicines that's been available for decades. You probably recognize the names like donepezil, rivastigmine, galantamine, and memantine. Prior to the recent approval of new medicines, the big development was this combination pill of donepezil and memantine in one tablet. But these older versions of the medicines, although they are symptomatically beneficial, they're not disease modifying. So this concept of symptomatic versus disease modifying treatment, that's what I'd like to try to go over here today. So if you look at this cartoon showing cognitive performance over time, let's look at this horizontal line representing the decline of cognitive function when Alzheimer's disease is not treated. If someone receives symptomatic treatment, you will notice that their cognitive function improves a little bit. But if you look at the disease course, the decline that happens over time, there's really no difference between people receiving the medicine and those that are not receiving the medicine. And that's what we refer to as symptomatic treatment. What we're really looking for is disease modifying treatment, where if someone receives the medicine, that decline happens more slowly. We are actually taking an effect on the pace of the decline that happens because of Alzheimer's disease. And until recently, there was no disease-modifying treatment for Alzheimer's disease. But I'm happy to report that we do have some options now. The new medicines target the amyloid plaques. Dr. Masaki mentioned that in Alzheimer's disease, there's accumulation of these pathologic changes, the amyloid plaques and the neurofibrillary tangles. The medicines that I'm talking about today focuses on the amyloid plaques. It clears them away from the brain. The medicines that have been approved so far by the FDA, the first one was aducanumab. But unfortunately, there was really no reliable or convincing scientific evidence that that medicine really works, even though it was approved by the FDA. And so despite the approval, the doctors were not using that medicine. And so it was actually taken off the market shortly after the approval. But the good news is that there are two other medicines that have better scientific evidence that they work. They're lecanemab and donanemab. And those are the medicines that are on the market today. Those are the medicines that are being offered to patients. Those are the medicines that we have available here at Queens. The thing to keep in mind is that these medicines are meant only for people who have Alzheimer's disease and for those who are still in the early stage of Alzheimer's disease. If somebody does not have Alzheimer's disease, they don't necessarily have plaques in their brains, and medicines that clear away plaques are not going to help them. And even for those who have Alzheimer's disease, those who are later on in the course of the disease, these treatments are not quite as effective. There may be greater safety concerns. So the FDA has made it very clear that we can only offer these medicines to people who are still in the early stages. So what does it mean to be in the early stage of Alzheimer's disease? So this curve represents the decline that we expect from people with Alzheimer's disease. The dotted red line represents when the diagnosis of dementia is made. Even before the diagnosis of dementia, there is this stage called mild cognitive impairment, where the person may seem quite functional, but when you actually test their memory function, we can see that something is off. That's mild cognitive impairment. When the condition progresses and they do get diagnosed with dementia, in the early stage, they are still functional. They may have some difficulty with complicated tasks like balancing their checkbooks and remembering to take their medicines, but they're still able to do most things on their own. By the time they reach the middle stage or the moderate stage, they actually have more difficulty with even more routine tasks, like getting dressed. And when the person reaches the severe stage, they actually need help with all activities of daily living, so they're quite impaired. So the medicines that I'm going to talk to you about today are offered to people who are still in the mild cognitive impairment stage or the mild stage of Alzheimer's disease. Once somebody reaches moderate stage of Alzheimer's disease, they're no longer eligible for this treatment. So this slide kind of refers to what Dr. Masaki was talking about, that as we enter the severe stages of Alzheimer's disease, it's pretty easy to tell that they have dementia. So this curve over here shows the cognitive decline that happens with normal aging. Everyone has some degree of memory impairment with aging. It's just what happens normally. But if somebody has Alzheimer's disease, their pace of cognitive decline is faster. And so later in life, you could clearly see that there's a difference between someone who has Alzheimer's disease and someone who is having memory impairment from normal aging. So this is easy to tell. But we are talking about medicines that need to be offered to patients who are in the early stage of Alzheimer's disease. So as we move up the curve to the earlier stages, well, the difference between normal aging and Alzheimer's disease become quite subtle, and it can be hard to tell. So we're not going to be able to make that determination just from examining people. We now rely upon biomarkers to tell us who has Alzheimer's disease and who doesn't. And the gold standard for making that diagnosis is the amyloid PET scan that was mentioned. So as you can see in these images, people who do not have Alzheimer's disease, the scan shows really cool colors, green and blue. Those who have amyloid buildup in their brains, meaning that they have Alzheimer's disease, the colors are a lot hotter, like red, orange, and yellow. So if we're talking about someone who is cognitive normal, comparing that to someone who has Alzheimer's dementia, well, even without this PET scan result, we can clearly tell that there's a difference. But what we're talking about today is someone who has relatively mild degree of memory impairment. If they're in the mild cognitive impairment stage, how can we tell who is going to have Alzheimer's dementia later and who is actually experiencing normal aging? Well, take two people in that situation and you do the amyloid PET scan. Well, if they show these cool colors consistent with normal scan, that person does not have Alzheimer's disease. But if we see these hotter colors, even though their memory function is not that bad, we know that they have Alzheimer's disease. So this makes it really clear who has Alzheimer's disease and who doesn't. As mentioned, the bad news is that this technology is currently not available in the state of Hawaii. The Queens Medical Center is diligently working on making this service available to people, and it will be available soon. Exactly when, I don't know. But what I can tell you is that they are actually holding meetings about marketing this service. So I think that we're getting very close. And so when we have this service available for people, I'm pretty sure you'll hear about it. There's going to be marketing advertisements letting people know that we're ready to go. So until the amyloid PET scan becomes available, how do we tell if somebody has Alzheimer's disease or not? Well, the only other reliable test is a lumbar puncture procedure, the spinal tap. And I know whenever I bring this up, everyone gets a little bit squeamish, but it is a reliable test. So we do need this result to tell us who requires the treatment and who doesn't. If you go through these testing and prove that there's Alzheimer's disease still in the early stage, well, what are the medicines supposed to do? Well, this cartoon shows early stage represented in gray and the later stages represented in red. What we're trying to do is identify people who are still in the early stage and keep them in the early stage for as long as possible by slowing down the pace of decline. And some people may hear that and say, well, that doesn't seem like much. What's the benefit, really? But if you think about it, there's a really big difference between someone who's still in the early stage of dementia versus later stage of dementia. For example, they may need more supervision. They're going to lose independence. There's going to need more surveillance. And the big thing that everybody talks about is as you enter into the later stages, you may not be allowed to drive anymore. That's a big deal. And so any options that are available to keep the people in the early stages, it can be a significant benefit. And so certainly a lot of people are requesting this treatment. The bad news is that there's no treatment out there that only does good things. There can be side effects and complications. And so what are the issues with these treatment? Well, first of all, you have to understand that this is infusion treatment that we're talking about. You're not going to be taking pills at home. You have to come to the infusion center and get the medicine through IV. And so there's lots of trips to the infusion center. There are two versions of the medicine, as I said. One of them is infusions every 2 weeks. The other one's infusions every month. Once a month is better than every 2 weeks, but this is treatment that's going to go on for 18 months. So there's a lot of time commitment that's involved in receiving this medicine. The other issue is that all infusion treatments are really expensive. So the medicine alone, as mentioned here, it's going to range in the tens of thousands of dollars per year. And besides that, you also have to pay for the nurses and the equipment that they use to get the medicine into you. And so the cost really adds up over time. So in the state of Hawaii right now, there are two insurances that have announced that they'll cover this treatment. It's Medicare and HMSA. For those people who have an insurance that's not one of these two, that can be a really significant financial burden in terms of getting this medicine. And even for those who have Medicare or HMSA, the coverage is not 100%. And even small percentages of tens of thousands of dollars, that could be a financial burden for people. So that's another issue that needs to be considered. And the third thing that we worry about is ARIA, amyloid-related imaging abnormalities. That is a potential complication that can happen with this treatment. There are two types of ARIA complications. One is hemorrhage or brain edema. Swelling, which is brain edema, or bleeding, which is hemorrhage. So people can get brain swelling and bleeding as a complication of this treatment. The good news is that most of the people, if this happens, it's a relatively mild symptom. They may get a little bit of headache, confusion, dizziness, nausea, things like that. And because of this risk, there are multiple brain MRI scans that are scheduled in the course of the treatment. If we detect the problem, we'll stop the medicine, and hopefully there won't be any serious consequences. But unfortunately, there are some patients that have experienced severe forms of this ARIA, and they can have bad consequences from it. And the scenario that we worry about, the age group of people that are receiving this medicine, they are at risk for having strokes. And when people go to the emergency room with something that sounds like a stroke, they're liable to give you medicine that can break up the stroke. That strong blood clot disrupting medicines given to people who are receiving this treatment, well, they can have serious brain bleeding complication. And some of the people in the clinical trials that found themselves in that scenario, they actually died. And so there's a big effort to try to educate the community and the doctors in the community, people who are working in the emergency room, to let them know about this complication. Hopefully we won't run into those issues, but everyone who is considering this medicine needs to be aware about that possibility. So here at the Queens Medical Center, we follow the standard guidelines. We've actually set up a multidisciplinary committee with doctors, including like Dr. Masaki and other geriatrics doctors, and we go over every single case of patients who are interested in receiving this medicine to really think about all the different possible reasons why they may run into complications, and we try to give them the best advice about whether it makes sense for them to get the medicine or not. And through this concerted effort, I'm happy to report that so far, we have not run into anyone running into this ARIA complication here at Queens. And hopefully I'll be able to keep saying that. I have a lot of people to thank for this endeavor. This is not something that I can do on my own. As I mentioned, Dr. Masaki and many other people at the Queens Medical Center have been very helpful. So I can't take the time to mention everyone by name, but I really appreciate everyone who's been involved in this process. So that takes me to the end of the presentation. I think we have a little bit of time for questions.